I have breast cancer, and I have a family.
I have breast cancer, and I have a job.
I have breast cancer, and I have plans.
I'm in treatment.
I'm triple negative.
I'm metastatic.
I'm BRCA positive.
I'm new to this.
I have breast cancer, and I needed someone to talk to.
I needed information.
I needed help with my bills.
I needed to know what chemo would be like.
I needed to know I could do this.
Living Beyond Breast Cancer is a national cancer organization
Created by and for women with breast cancer.
And those who love them.
We provide support and advice,
organize programs and activities
to raise awareness and hope.
I have breast cancer,
And I have support.
I have information.
I have advice.
I have breast cancer, and I have hope. I have Living Beyond Breast Cancer.
Good evening, everyone, and welcome to Living Beyond Breast Cancer's 360 Balancing Act, Treatment Choices and Side Effects in Metastatic Breast Cancer. My name is Janine Guglielmino, and I'm the Senior Director of Programs and Partnerships for Living Beyond Breast Cancer, and I'm very pleased to serve as your moderator this evening. I want to welcome all of you from across the country and maybe from around the world to our program tonight and encourage you to text us questions throughout the program, and we'll get to as many as we can. Before we jump into our topic for tonight, I would like to thank our sponsors for making this program possible. Thank you very much to Lilly Oncology, Genentech, Daiichi Sankyo, Chico's FAS, and Celgene. Tonight we'll be talking about a very important issue, which is making treatment decisions in metastatic breast cancer. And whether you're on your first line of therapy, your second, third, or beyond, there are many choices to make. And the environment has gotten much more complex in the past few years. So you may have many choices, even with the first line of therapy. We're here tonight to talk to a panel of experts who will share how they make these types of decisions from their perspective, and to give you some practical tips on ways you can go back to your doctor and have a conversation about making these choices. And again, I encourage you to text your questions throughout the program, and we'll answer as many as we can. I want to start by welcoming our panelists. I'll start with Sheila, who's here in our Philadelphia studio. And I'd also like to welcome Marina, who is joining us from Florida today.
Hi.
And finally, I'd like to welcome Dr. Paula Almeida, who is a breast medical oncologist and a member of Living Beyond Breast Cancer's Board of Directors. So we're very pleased to have all of them here with us today, and we'll be taking your questions. My colleague Lynn Folkman will be taking them throughout the program. Thanks for being with us, Lynn. For our format tonight, we'll start off with a short conversation with Dr. Maida, and then we'll speak with our two panelists who are living with metastatic breast cancer, and then answer your questions. We'll get to as many of those as we can. So Dr. Maida, let's start with you. You are the Director of Integrative Oncology and Practice Development at MD Anderson Cancer Center at Cooper in Camden, New Jersey. And while we were preparing for the program, you had shared with us that you see a significant proportion of patients with metastatic breast cancer. So you're having these kinds of conversations every day.
Every hour.
Every hour. So you have a lot to share with us. Let's say you're speaking with a patient for the first time who's just been diagnosed with metastatic breast cancer. How do you begin to have that initial conversation about treatment options?
Yeah. Well, thank you again for having me here. And I see, before I came here, I actually counted how many patients I'm actively seeing right now. And there's about 150 patients that I'm managing right now with metastatic breast cancer. And I think it's important to tell each and every one of them that their diagnosis is different, that metastatic breast cancer does not represent one disease. It really is dozens, if not hundreds of different diseases that have different treatment algorithms and different pathways and different options and different symptoms.
And how easy is it to explain that to someone who's dealing with sort of the stress and emotion and reality of being diagnosed with metastatic breast cancer?
So what I do, I think I would separate this into two types of patients. There are patients who have had breast cancer earlier, who then have a recurrence that is metastatic. Those are patients that I probably already know, or at least I've been seeing for some time, and I think I've developed a relationship and some rapport with them. So those conversations are different than, for example, a patient that I see who is showing up with stage 4, which officially the definition of stage 4 is a patient who shows up with metastases. The conversations, depend on family members, who's in the room, and really I let the patient, at least initially, take me to where they want to go, what they want to talk about before I begin the treatment options.
So say you're meeting with this patient for the first time. One of the things that we, again, had talked about in planning for the program is how much medicine has changed just even the last few years. There's whole categories of treatment that didn't exist before 2017. And how has that complicated the conversation about treatment?
I think it's complicated the conversation in a really good way. When I treated my first patient with breast cancer about 15 years ago, which is a relatively short period of time, but the conversations I used to have at that time are completely different, not just in terms of the options, but in terms of the sort of hope we can give women with metastatic breast cancer. I would say the last few years are where we've seen a fairly dramatic shift in the whole approach, and that has to do with our ability now to really look at the genes of the cancer better. And soon, and it's already starting, try to figure out what those genes are telling us and what treatments we can give according to those genes and how they're mutated.
Great. So tell me a little bit about what are the sorts of things that you want to know about a patient before you recommend treatment?
So I think it's important to get a sense of a patient's health. Just because we have 50 options at our disposal doesn't mean all 50 are appropriate for that patient. So patient's age, their medical history, which is really important. What sort of issues they've had just through menopause. Are they premenopausal, postmenopausal? And then the cancer itself, which we talk about these receptors and estrogen and HER2 and what the expression patterns of those receptors are and how they would determine our options.
Great. And how might the conversation look different after a first progression, for example? So you and your patient have agreed on a treatment, you're hoping it will last for a long time, and then that first progression, you have to make another decision. How might that conversation look different than the initial one?
So that depends a lot on how long it's been on that progression. For example, a patient who comes in who I start treatment but 3 months later has progression really is a different conversation than a patient who may have been on a treatment for 5 years and has had a progression. Even our options tend to be different. We tend to make bigger changes in our treatments when patients progress more quickly. We always want to, and I know we'll talk more about this today, but we always want to consider clinical trials. I think patients sometimes have some misconceptions about clinical trials and what they mean, and even from the get-go, there can be really good clinical trial options that patients should always think about.
And we'll definitely be talking about clinical trials this evening. So I thank you for that. Are there things as a physician that you've learned about a patient later that you didn't know that you wish you had when you were making a treatment recommendation?
I think it really, they're health issues. Patients sometimes are reluctant to tell us all of their history when it comes to treatment options, because I think sometimes it makes them feel like it would limit their options. As we're going through treatment, we tend to see that patients, at least as far as the physicians, may not tell us exactly how they feel on treatments. If they're not doing as well, they may tell their family, or their family may see it. But to the physician, we often hear that everything's going okay, which is why I always like when family members are there. I tend to worry a little bit when patients come alone to all their visits because I feel like sometimes I'm not getting the whole story. I also rely heavily on my nurses. My clinical nurse, our infusion nurses, they have the patients sometimes for hours. And so they may get to talk to them a lot more than they talk to me.
I think that's a really important point about sort of the community, both of healthcare workers around you and of your family and your support people, being able to even maybe see things that that you might not notice or might not think of at the time of the appointment when you have the doctor's attention. So I think that's an excellent point.
I mean, right off the bat, a patient doesn't just meet me. We really try to get them to meet our whole team. There's I'll have my right hand, which is my clinical nurse, who'll get to know the patient very well, but also all the other members from our social workers, our navigators, our nurses, our infusion nurses, our medical assistants get to know our patients. So this way, someone may pick up something that everyone else is not, and then report to us.
Excellent. So when you're talking to a patient, what are the sorts of things that you would advise a person to be thinking about when they're selecting a treatment? What would you want them to be considering?
You know, I think when it comes to a patient who is newly diagnosed with metastatic breast cancer, it's something that after hearing the story, after looking at the pathology and all the tests that they've had, I will make a recommendation that I think is appropriate. Sometimes there's a few options that we'll discuss. And from there, then a patient responds to me and says yes, or what other options there might be. I think early on, patients tend to look to us for the recommendations. As a patient with metastatic breast cancer may have gone through a few different treatments, not only does my approach change, but I think a patient's, their own sort of contribution to their decision-making changes.
Can you tell us a little bit more about that? What differences do you see in your patients?
Yeah, so I have patients, I mean, because we have so many options in breast cancer, there are numerous patients who will have had 6, 7, 8 lines of treatment. And at that point, obviously, we will continue to provide whatever options we have. But at that point, a patient is somewhat of a veteran in their process. So they understand side effect profiles, they understand the pros and cons better. And what we tend to see is they may come in themselves with some ideas about what they've heard about and read about. And by then, obviously, we've known those patients pretty well, and they're just more educated about their decision making. So as oncologists, I think we trust their decision making more because we feel like they've been through it, and they're often correct. The issue with our decisions later on after third and fourth options is that the data is not as clear on what to do. So once we get past about 3 or so options, most of the clinical trials aren't looking at that specific subset of patients. So at that point, the options are less clear evidence driven, but rather our own experience, patient side effects, patient health, patient diagnosis. The other thing that tends to happen a lot more now than it did a few years ago is that even after a few lines, we may biopsy again. Well, I never used to do that 10, 15 years ago, but now it is not unusual for a patient to have a biopsy even each time there's a change.
And how do you have that conversation about biopsy? I know sometimes it's hard to biopsy a metastatic site. There could be pain. How do you have that conversation?
It is a conversation that I tend to have early on, setting the stage for what I think a patient should hear from the beginning, which is that here's the course of this, where we'll start here. Assuming this works, you stay on this. If it stops working, then there's a possibility, if there's something there that we can put a needle into, we'll do it. If it's safe, if it's a place that you can safely biopsy. Often, if the progression is different than the original situation.
At a different site or?
A different site, or just a change in the pace of progression. So a patient who may come in with a few sites of metastases who suddenly has a lot more sites, just clinically we feel that maybe there's been some change in the diagnosis, and so a biopsy would be done at that point. So most biopsies now with our radiologists and other specialists are usually feasible.
That's really helpful information because I think it's a biomarker testing, and this kind of testing is newer, and so really important for people to understand what that's all about. And another issue that you brought up, Dr. Maida, is sort of how people gain more experience over time. So something that we've created at Living Beyond Breast Cancer is a list of questions that you can download from lbbc.org, and I think we're going to show that on the screen so that folks can see that. These are just 10 questions to ask about treatment, and they can be especially helpful if you're newly diagnosed and you're just learning, but it also might just trigger some other questions that you can take with you when you go to see your physician if you're not really sure how to start the conversation about treatment. So I want to thank you, Dr. Maida, for this conversation. It's been really, really helpful. And I now want to turn to our other experts, Sheila and Marina, who, when added together, have 15 years of treatment experience to share with us. So they really have a lot to say. And, you know, both of them have experienced a number of progressions and can share their stories with us. Sheila, let's start with you.
Thank you.
You've been living with HER2-positive, ER-positive metastatic breast cancer for more than 10 years, so you certainly qualify as a veteran in a number of ways. And you were diagnosed with stage 4 disease from the start, so you were de novo, as Dr. Maida was explaining. Tell us about when you were first diagnosed and what you understood about the goals of treatment at that time.
Well, thank you to LBBC for having me here, because you know I love you all. And thank you, Dr. Maida, because you said exactly what helps somebody that's newly diagnosed. And I wish I kind of knew that information when I was first initially diagnosed. That would have been great to have conversations like this. But when I was diagnosed, I was active duty military, as some know, and I did a mammogram, and I had a pain, and I said, something just doesn't feel right, and ultimately it had metastasized to my liver and ribs. So they sent me down to the hospital that I go to, and they sent me to my doctor, and it just seemed like we automatically just hit it off. I didn't know metastatic meant stage 4. My mom had died of metastatic breast cancer in 2004. 5 years later, I got it. And I didn't know that those two words, and the first thing I asked my doctor was, well, how many stages are there? Because I didn't know. I guess I was just blind. And she said, oh, you got all of them. And I was like, huh? So we decided then that I said, well, what are my options? And my options was, I said, I want to treat it aggressively. I said, let's go for it, because at this point I have nothing to lose. And she said, well, we're going to start off with Taxol and Herceptin. And she explained what Taxol was, and she explained Herceptin is for HER2. It hits the HER2 cell or gene. And I was like, okay, we're going to start off with that. And ultimately it worked because I went stable for 3 years after being on Herceptin and Taxol for it was 9 months. I was on 3 weeks on and 1 week off. And so I was like, okay. And then it started progressing again. So I'm on probably my 7th line of treatment right now. I know we're going to talk about clinical trials later. But I just think that is important to have that patient-doctor relationship. I think it's important that you take somebody with you because you're blinded. You just, and my thing is, I thought chemotherapy, it's going to shrink, it's going to shrink, it's going to shrink. But it never shrunk. And I'm just like, well, why isn't it shrinking? So, my doctor explained it to me was like, after 3 months, we'll give you another scan and we'll see how you're doing, because she said, you really can't really tell till after 3 or 4 months. So, that's when they say that metastatic breast cancer patients, we ultimately live 3 months at a time, And she said, well, it's not shrinking, but is stable. So I'm like, well, what does stable mean? So I'm crying and I'm like, I don't know, I want it to be stable. And she said, yeah, Sheila, you want it to be stable. What we don't want is for it to progress. So I'm like, oh, okay. So I stopped crying and I'm like, okay, so now I get it. So ultimately for 10 years, that's what our goal was, is to keep it stable and keep it from progressing. So I've had 4 progressions within this 10 years, and I've been on Taxotere, and I said, let's go aggressive with it each time. And it seemed like my doctor always calls me when I'm shopping. And she says, Sheila, it's progressing because your tumor markers are up, and we're going to do a scan, and the scan says this. But it's just that we have that. I never even thought about getting a second opinion. I actually didn't even know that I could get a second opinion. I just thought I had to go to this doctor. I was so blinded by just trying to understand the disease and understand that this disease is what stole my mom, so.
Well, Sheila, thank you so much for sharing that. And you've described so well, I think, the way when you get that initial diagnosis, you had these memories of your mom dying of metastatic breast cancer. You didn't understand the medical terminology. There was so much being thrown at you. And as Dr. Maida was reflecting, you really were trusting your oncologist to lead the way and to give you good guidance. And I'm wondering if you can talk a little bit about what makes your relationship with your oncologist trusting. Why do you trust her? What are the qualities? Because I can call her at any time, and within an hour, 2 hours, her nurse, and like Dr. Maida said, I have a great relationship with her nurse, and her nurses around me, because sometimes I don't understand the terminology. So I'm sitting like, I'm gonna wait till her nurse come in, and I'm gonna have her, talk to me about what she just said. And the nurse will come in, and I say, so break it down to me where I understand it. And she'll come in and she'll say, well, this is what she meant by it, and But I can call my doctor, and an hour, 2 hours later, either she's calling me back or her nurse is calling me back. So we just have, I asked her on Monday I had treatment, and I'm on the plane like, please don't let me puke, please. On the way here, and I asked her, I said, can you believe I'm still here? And she was like, no. She said, it's remarkable. And I said, I'm just doing what you're telling me to do. I'm just doing exactly, what you said we were going to do. We're going to treat it aggressively, and I'm going to go with what, I'm trusting you. And, I've trusted her for 10 years. And we just clicked. We just had that. And she told me when we first met, she said, Sheila, if anybody ever comes up to you and they don't have that bedside manner, she said, you tell me. And she said, remember to bring somebody with you, and, and even, I suggest you bring a recording with you. We got it on our phones, just so if she says a term or your doctor says a term that you don't understand, you can go back, or bring a journal in with you so you can write down everything or whatever. Because I was reading my doctor's notes Monday, and she said, I have a pleasant 53-year-old. I said, oh, so I'm pleasant now. And she started laughing, and she said, oh, I said, so that's what y'all write about us. Yeah, so we just, I just decided on my treatment options just from talking to her and just trusting her and reading. I don't read the internet a lot because it gives you a lot of bad information, but I do go on the internet and say, okay, Taxol. And actually, I learned about TDM1 from the conference here at Living Beyond Breast Cancer. I took it back to my doctor and I said, well, maybe we might need to try TDM1, which is cat salad now. She said, oh, I didn't think of that. And what do you know? I was on it, and it worked. So I think that's also when we'll talk more about this, about the use of social media and about going online, and some of the strengths and the perils of that. So I think that's a great story to share. So I really appreciate that, Sheila. I want to bring in Marina now into our conversation from slightly warmer Florida than here in cold Philadelphia. So Marina, thank you so much for joining us today. Marina,
it's a pleasure to be here. Thank you.
Thank you. So Marina, you were diagnosed 5 years ago with stage 4 triple negative breast cancer, and this was 3 years after your initial diagnosis with early stage breast cancer. So a big shock to have the cancer recur. Can you please share with us how you made your first treatment decision after your metastatic diagnosis?
Sure. So yes, it was a big shock. But my cancer, when it was diagnosed as metastatic, was oligometastatic. I had a single met. It was in my sternum. It was large, but it was the only one. And that gave my oncologist like a little bit of optimism. And I heard the word curative intent being thrown around. And he said to me that sometimes people with oligometastatic disease actually have a pretty durable response and pretty good outcomes if they take a very aggressive approach. And that means more than chemo. I mean, chemo was obviously in the cards, but it also meant a surgical approach. And it would be a pretty radical surgery in my case because it would actually mean removing my entire sternum. So I thought about it. I went for multiple second opinions, I think 3 or 4 second opinions. I read up in the literature, the peer-reviewed literature. I looked to see cases with oligometastatic disease and what the outcomes were, and really weighed up that decision. The second opinions were all over the place. I want to say some were for it, some were violently against it. In fact, one of the oncologists that I spoke to for a second opinion, she said to me, "What are your hobbies, Marina?" And I said, "Well, I enjoy gardening." And she says to me, "Oh, you'll never garden again if you have this surgery." So it was really very scary. I knew it was risky. I knew the surgery was complicated. And there was a high rate of complications from having a sternal resection and reconstruction. But I decided to go with it, go that super aggressive approach. And I think it was because I had that slither of hope, being oligometastatic, hearing the word curative intent, that really stuck with me and, made me go for that pretty dramatic, I want to say, approach. So I had chemotherapy and then I had the sternal resection and reconstruction, and that was actually followed with radiation and proton therapy. And I want to say the surgery went surprisingly well. My recovery was really quick. The surgery itself was there were no problems with the surgery itself. My recovery was much less painful than I thought it would be. I didn't have any debilitating long-term effects. And in fact, I took up gardening again quite soon. So that didn't happen, that I could never garden again. In fact, I've even added some hobbies. So I want to say it was a really good decision. I mean, of course, in the end, it turned out it wasn't curative. I did have progression, and I've had a lot of progression, but I have zero regrets about making such a decision about being so aggressive.
Well, Marina, one question I want to ask you, since you got multiple second opinions and they were so different, how did you make that choice? How did you decide which opinion was the right one for you?
I think I really thought about it, discussed it with everyone I could. I'm very much the kind of person that's not private about having metastatic breast cancer. So I'll talk to anyone and everyone about it and get lots of people's different opinions. Talk to my husband a lot, my family, my friends, people in the metastatic breast cancer community. And again, I think going to the peer-reviewed literature was very helpful. And every cancer center I've ever been to has a resource room. And in that resource room, you can look up any kind of peer-reviewed literature you want to. So it's very accessible to us.
So you have that literature, and then what do you do with it in terms of talking with your doctor? What is your relationship like with your main oncologist?
So my oncologist now is absolutely phenomenal. I'm extremely lucky. In fact, I've actually had phenomenal oncologists all the way through. I've moved several times since my diagnosis of metastatic breast cancer. So I have had a few different oncologists. My relationship with my oncologist right now is just extraordinary. I would say it's definitely a shared decision-making approach that he takes. He's absolutely brilliant. He knows his stuff, and he'll spend all the time in the world with me that I need. And most importantly, I think he really respects my needs, my opinions, and my preferences. So he'll bring the facts to the table based on his vast knowledge and his experience. But ultimately, I feel like he really empowers me to make the decision. So I can really base the decision on his opinion, on what I think I need, and on the literature that I've reviewed and the people I've spoken to. Also, my husband is at almost every visit with me, and definitely every restaging visit. And he's a great sounding board for me and a huge support in my decision making. So that's the kind of relationship I have with my oncologist. It's very respectful. I completely trust him. He's got all the time I need. And he's also thinks outside the box. So I have metastatic triple negative breast cancer, which is a very tricky type of breast cancer. There are no targeted treatments. So I think oncologists really have to think outside the box with breast cancer in general, but especially with triple negative. And he really does that. And I've had remarkable luck with managing side effects. And I think I owe that to my oncologist's very individualized approach. He really puts his patients first, and he works very closely with me to tweak things so that quality of life can be maintained.
Something that you said before, Marina, that I thought was interesting with the less positive experience you had had with an oncologist was that physician had asked you about your hobbies and sort of asked you about your day-to-day life. Does your physician tend to ask you about things that you want to do or goals that you have and integrate that into your treatment recommendations?
Yeah, he does. He's very mindful of the fact that I like to be very active and that I'm not a martyr, so quality of life is very important to me, and he keeps me extremely comfortable, and often with things kind of outside the box, like lowering dosages, quite readily. Mm-hmm. Obviously, I have all of the standard things that help me manage side effects, but he's really, really tailors things. And so often he'll turn to me and he'll say, because I don't like steroids. And so he'll say to me, what dose steroid do you want? So, it's like so individualized and so personalized and so respectful. I really, really appreciate him.
So thank you so much, Marina, for sharing that. And I think that's interesting, what you were saying about not wanting steroids and that conversation. So I want to actually turn to Dr. Mehta and kind of follow that up with how you deal with situations, Dr. Mehta, where a patient might not want to pursue a treatment, and how you have that conversation and the sorts of things that you might think about.
Yeah, and if I can say, a lot of great points were brought up here by Sheila and Marina, and the decision to start a treatment, to start a new treatment, I always say our job as physicians, as oncologists, is to provide information, not to make decisions, but provide information so patients can make informed decisions. What I've noticed has happened over the last decade or so is that we have seen more and more proliferation of misinformation, to use the colloquial fake news. What's happened is I think it's become really difficult for patients to filter the information that they're seeing on social media, on the internet. The plug for LBBC, of course, is that we certainly provide well-researched, evidence-based information. And so when I offer a treatment, it is not out of the ordinary for a patient to initially say no, but I always try to find out the why behind it, because I think sometimes they may have a misconception. I think Sheila spoke to this a little bit, misconception about treatment, about what chemotherapy is, all the different types of chemotherapy, hormonal therapy, particularly the side effects associated with it sometimes are, and certainly some patients have a lot of side effects, a lot of patients don't. So I think it's important to understand the why. And often and again, I'm not trying to persuade patients to do something, but I want them to understand that the treatments may not be what they think in terms of how they feel.
Mm-hmm. Mm-hmm. That's a really excellent point. And it kind of leads me to another issue which we definitely want to discuss, which is clinical trials and perhaps trying a treatment where you might have less information about what the side effects are going to look like. And both Marina and Sheila have participated in clinical trials, but I know, Sheila, right now you are participating in a clinical trial and have been.
Yes.
Can you tell us a little bit about why you decided to receive your treatment through a clinical trial?
Well, my doctor, I had a progression in July of 2018 on my 4th rib. And she said either we can go back on Taxol, we can go back on Taxotere, or we can try this clinical trial. And she was real excited about it. She said, you know, it might be the next Herceptin. And then she said, I have an 80-year-old woman that's on it, and she's doing really good. And I'm like, okay, now if an 80-year-old woman can do it, I can do it. So we decided on a clinical trial, and I saw my clinical trial coordinator, and she told me about some of the side effects and different things like that. And I just decided, as a African-American woman, you know, only 1% to 3% of African-American women participate in clinical trials. So if I am going to advocate for clinical trials, I'm going to not only talk the talk, but walk the walk. And this is not just for me, it's for future generations, you know. God forbid that my daughter ever gets it, or any of our, you know, kids or men get breast cancer or whatever. This will help them in the long run, you know, if not now, but years down the road. So, you know, it was a lot of, you know, I talked to my husband. He said, well, why are you going on this experimental drug? You know, because it's not, you don't know, and I didn't know. So I explained to him what it was, and he said, oh, okay, so now I understand. And then we just decided that, okay, let's just go for it. And you know, the results from it, I've been on it for 16 months. I just had a scan on Wednesday. I'm still stable. And yeah, you know, so I'm doing good on it. And I asked my doctor, well, when the clinical trial ends, what do we do? And she said, you'll still stay on it. She said, we already got protocols in place. We already got everything in place. You'll just still stay on it as long as it's working. And I was like, okay. So you really don't know what questions to ask a clinical trial. You kind of just go through it, you know, and then you ask questions along the way. But it's a process. It's a process.
I really appreciate you sharing that, and also when we were preparing for the program, you had also mentioned that one of the reasons that you participate in a clinical trial is that you wanted to show it wasn't a last resort, right. Which I think is a really common belief. And I'm wondering, Dr. Maida, how do patients ask about clinical trials, or does it have to come from you? Where does that conversation begin?
You know, again, it depends on the types of patients. I mean, there are some patients that really will just look to us and say, what do you think? Does this make sense? Doesn't it? Others will come with a plate of, I had got an email from a patient yesterday with 8 different clinical trials nationally. And so I'll go through them and I'll go over what I think would make sense, and then reach out to the clinical trials team at that institution and let them know that there's a patient who's interested. I think the important thing, what you mentioned about clinical trials, is that for some patients, there is this fear that clinical trials is the guinea pig approach, that we are experimenting on people in a way that, you know, could be unethical, which, of course, you know, by multiple, not just laws, but our own morals around treating patients, we would never give a patient a clinical trial option if there were a better option available. So most clinical trials are, the idea behind them is to say that if they are randomized, which many clinical trials are, that you would get potentially what your oncologist would want to give you anyway, or potentially something just as good or better. And so there are various types of clinical trials, and I think for some patients, and I believe what you're on is a similar type trial where everyone gets the option, gets the drug. So this idea that we would give a placebo when there's something better available, obviously does not happen. And clinical trials, it is important to remember that it's actually a good idea to seek them out early, because most clinical trials, as anyone who's gone through them, you'll know that clinical trials accept patients who are reasonably healthy, who have what we call a good performance status, the ability to get around, to garden, to shop, to live your life.
Thank you for saying that.
Yeah.
That will help a lot of people.
Yeah.
Yes, absolutely. And I know I want to turn to Marina and give her an opportunity to say something, because I know, Marina, you've also participated in a number of clinical trials with immunotherapy and with some other kinds of treatments. And Marina, you're also very active online. So one of the questions that I have for you is, what sort of things you hear in the community when people are making treatment decisions, either around clinical trials or about any treatment decisions in general? What do you hear in the metastatic community that you would want to share about treatment decisions?
That's a really good question. I like that. And I'd like to just go back to what Dr. Maida said about patients coming with information, and how the internet and fake news and whatnot can be an absolute minefield of misinformation. And I've noticed that people in the metastatic community, metastatic breast cancer community, are actually very savvy consumers. Most of the social media groups that I belong to have zero tolerance for sort of fake cures or misconceptions, and are very sort of evidence-based and credible in terms of the information. And we always push for people to get information from credible sources, from your oncologist, from something like LBBC, from the peer-reviewed literature, and avoid those sort of alarming things that really are very can mislead you. So I think I want to say we're savvy consumers of the evidence that's out there. I'm a huge fan of trials, I have to say. I've actually participated in 7 trials, 6 in the metastatic setting. I think trials present a unique opportunity to get access to innovative treatments. A friend of mine said, how else am I going to get a treatment that might only be available in 6 years' time? It gives you access to more treatments. So for me, that's especially important, because with metastatic triple-negative breast cancer, the only options are quite limited, and generally limited to cytotoxic chemo. And there's nothing that's targeted and nothing that's terribly effective. So to me, a trial gives me hope that I might find something, I might stumble on the Herceptin for HER2, something that will give me a durable response. And also I found that trials are helpful for me in terms of my quality of life. So with triple negative, all I've had in terms of standard of care is cytotoxic chemo with all the side effects. But all the trials I've been on have been more targeted. So in fact, the side effects are much less in terms of the trial drugs I've been on. So my quality of life has been better when I've been on a trial. And then there is kind of that feeling of being part of something that's bigger than yourself, making a contribution to the advancement of cancer treatments. And that, gives me a little bit of a joyful feeling. But I think there are a lot of advantages to participating in trials, and definitely not a last resort. As Dr. Maida said, the biggest problem we have is that we become quite quickly considered heavily pre-treated, which is my case. I'm extremely healthy and I garden and I do all kinds of things, but I have had a lot of lines of treatment. I've actually had, I think it's about 14 lines of treatment so far. And so I'm very heavily pre-treated, and that means that I'm excluded from many clinical trials, despite my feelings of good health. And that presents a huge barrier, not just for myself, but for many people who want to participate in the trial and probably could, but are shut out of trials.
I really appreciate you talking about that, Marina, and that's something that Living Beyond Breast Cancer, as a member of the Metastatic Breast Cancer Alliance, we're really trying to make some movement on allowing people who are more heavily pretreated, who have brain mets, and who have other issues that typically prevent them from participating in a clinical trial from being able to join. So we are working toward making some changes there. So with that, I am actually going to pass things to my colleague, Lynn Folkman, because I understand we have a few questions from our audience.
Yes. So I'm actually going to continue with Marina on this question, since we're talking about clinical trials. Where do people, it sounds like you've done a lot of research. Do you have any recommendations on where people can actually locate and find these clinical trials? And a part B, if you have recommendations, is also what about people who are maybe in a more rural area and getting access to those clinical trials?
Wow, those are two great questions. So I've been fortunate in that my oncologist is great about working with me to find clinical trials. So that, I think, would be definitely the place to start for someone is, have your oncologist work with you to find clinical trials. There are lots of search engines out there, and clinicaltrials.gov, is a search engine that's been improved over the years. The Metastatic Breast Cancer Alliance is working on releasing an amazing trial finding method. I have a friend who has a website called stormriders.com that is incredible in terms of a resource for finding trials. So there are these search engines, but I feel like it's really good for you in terms of your relationship with your oncologist to work with your oncologist in finding trials. And I've been fortunate that my oncologists have been very aggressive about helping me find trials. Also, I make connections. So I was at another oncology site on a clinical trial and made a very good connection with the oncologist there and the nurse coordinator there. And they actually send me information, which is amazing to me. So I think it's, wherever you go, just keep asking and people will help you out. And I'm sorry, what was the second part of your question?
The second part was if there's people in rural areas that maybe don't have that access, are there any other resources you might recommend?
Maybe Dr. Maida, could you address that?
Yeah. So I think there are patients who will be in a practice where there's not an academic center around for 200 miles. And what you might find in those places is your oncologist, even if it's a smaller group, may actually participate in clinical trials. So you don't necessarily have to have a large institution to have clinical trial access. The larger institutions will certainly have more resources, more options. But I think to touch upon what Marina was saying, the internet really can be a tremendous resource for trial options. The clinicaltrials.gov is a complicated site, but it certainly has gotten a little better and a little easier to navigate. But I think patients forget that they can actually also attend some of the bigger conferences that we have. Now, that does involve a little bit of travel for some patients, but for example, in a few weeks, we have coming up the largest breast cancer conference in the world in San Antonio, and I can tell you there are some patients who are celebrities there that we see every year, and there's a whole group of patients that come with different diagnoses, and they really learn a lot, and then they can go back to their communities and potentially be a leader in helping both themselves and some other patients. But I agree, I think talking with your oncologist and letting your oncologist make their connections with their colleagues, and often in rural areas, the vast majority of oncologists you'll see will have those connections because they may not have the same resources.
And for those of you who aren't able to, say, make it to a big cancer conference, that's not to toot our own horn, but at Living Beyond Breast Cancer, we try and bring you reports, and many of our colleague organizations do as well. There's a lot more live streaming of conferences from our organization and from others where you can learn about open clinical trials. And I think, Sheila, you said you had learned about some of the medications you ended up taking at an LBBC conference. So there are other ways to access that information if you're not well enough or you cannot afford to take advantage of that. Lynn, do we have another question?
Yes. Dr. Maida, there was a question about differences between an integrative oncologist and also how they could locate an integrative oncologist in their area.
If I can just mention one other thing for the previous question. The websites of large institutions have gotten a lot better. I'm with MD Anderson Cooper, and our main site, MD Anderson in Houston, has a tremendous site. Sloan Kettering, Dana-Farber, every major institution now, you can easily access clinical trial options, and they list them in a user-friendly way. So integrative oncology. So there's a lot of differences in how I think that is put into practice. So I always tell patients, I'm an oncologist first, meaning I still am a conventional medical oncologist that will treat you with the right breast cancer options. The way I look at integrative oncology is that I would then use other modalities such as nutrition, such as physical activity, mind-body practices to help patients manage symptoms, improve quality of life, improve physical and emotional health, manage fatigue, etc. I think patients probably need to be a little careful about the title of integrative medicine and just make sure that when they're going to see somebody for their breast cancer, that they really are seeing an oncologist who treats breast cancer as their primary day-to-day job and not an occasional patient. I think there are terms out there from complementary to holistic to alternative to integrative, and I think it's important for patients to try to do a little bit of homework on who they're going to see.
Thank you. I'm actually going to stick with Dr. Maida for this as well. We've had a lot of discussions with both Sheila and Marina and yourself in regards to quality of life issues. There's a lot of questions about whether it is debilitating weight loss or fatigue, or just all the medications to manage the side effects of one medication. How do you weigh that and talk to your patients about that, and how are those decisions best made? And if perhaps someone feels like their physician, their oncologist, is not listening to them, how would they best approach that?
Yeah, I think Sheila or Marina touched upon this, but the idea that you want the kind of relationship with your oncologist where you really can talk about these things and talk about either delaying treatments, lowering doses, which we do, and most of us, I think at this point, are fairly willing to do for our patients with metastatic breast cancer. Quality of life is always at the forefront of what we do from the very get-go for patients with metastatic cancer. And I think it also depends on where we are in the whole course of the situation and how healthy patients are. If patients really aren't that healthy and they're not as active and their performance status, which is again their ability to just function, is not as good, then the treatment options we should be offering really should be easier to handle. Again, the integrative piece of it is where we can manage or try to manage things like weight loss, nausea, fatigue, those sorts of things. But ultimately, it boils down to making decisions about the treatment itself, because that's really what would make a difference in side effects.
And also, can you talk about where palliative care would fit into that equation?
Yeah, that's a great question, because I think there's a lot of misconceptions about what palliative care really is. I think the term we often use interchangeably with hospice care, and that is certainly not the goal of palliative care. At one of the institutions where I am, I instituted a program where every patient with metastatic breast cancer from day one meets with a palliative care physician. There is good data now that shows that not only do you improve symptoms and and improve quality of life, but you may even improve outcomes with that. So when a patient feels like they have somebody there who's listening to their symptoms and really actively managing them, they tend to make better decisions for themselves.
Thank you. As well, when is it appropriate, I know these are, individual discussions, but to stop treatment, to stop a particular treatment or to stop treatment altogether?
Yeah, so that is a difficult conversation, and I think it's rarely a surprise conversation. As an oncologist, I think it's incumbent upon us to, as things are going along, as patients may be declining, to really start to introduce these ideas earlier on, as they're getting more tired, as their blood counts may be dropping, and really not just to them, but to their families and friends that may be with them, just incorporating everyone into that conversation, so that if we get to a point where a scan just continues to show changes and our treatments, the side effects of treatments are outweighing the benefits, and clinical trials may not be an option, then it's time to have that conversation. And hopefully by then we've had palliative care already part of that meeting. If we haven't, it's not an individual, not a uniform conversation. It really is an individual discussion with that patient and really going over what their goals and how they want to spend the time they have left.
Thank you. Could you also say a little bit more about immunotherapy?
Mm-hmm. Immunotherapy is the buzzword right now in cancer in general. Some of you know that there are a few immunotherapy drugs that are now approved, not just in breast cancer, but multiple cancers. And immunotherapy in breast cancer is relatively new. We had the first approval just a few months ago in triple-negative breast cancer. There are several compounds in the works. Immunotherapy is essentially, to put it simply, the drug itself is not fighting the cancer. The drug is making your immune system active again and fighting the cancer. The treatments that are out right now for breast cancer, their job is to, we say, sort of take off the brakes of the immune system, because cancers sometimes put the brakes on, or the blindfolds, and some of the drugs in the right patient can really do wonders. It's still early in the process, and I think that's where we want to be cautious, but also be enthusiastic about clinical trials in this arena.
Thank you.
Well, this has been a really wonderful conversation, and I appreciate all of your contributions. So before we wrap up, I want to give each of you an opportunity to say one more thing, and I'm going to start with you, Marina. So Marina, when you are making any particular treatment decision, what is the most important question that you ask yourself?
So to me, it's a difficult decision. I think it's especially tough in the metastatic breast cancer setting, because it's always difficult to predict a clinical course. We're all so different, our cancers are so different, and the treatments, as you said at the beginning in the introduction, keep evolving at an incredible rate, which is exciting, but it's also mind-boggling and makes that decision-making process even harder. I think it boils down to me thinking, is this likely to have a durable response for me without adversely affecting my quality of life? And I think above all, it's important for everyone to know not to have regrets. I've made many decisions that with hindsight didn't pan out, but I have no regrets. I've made those decisions within a given context, with the information that I have available at the time. And at that moment, it's the best choice. So, I say no regrets. That's my motto.
Thank you. Dr. Mehta, from your perspective as a physician, what is the most important thing that you think about when you're making a treatment recommendation?
I think about the person sitting in front of me and what their goals are, who they are, where they're coming from, where they want to go, and really just have them understand that breast cancer is not just breast cancer, that there are so many varieties and so many different courses that they want to be careful just not thinking that if their mother had it, if their sister, if their friend or their colleague or their whomever had it, that's what's going to happen to them, good or bad, and that it's a really individual story that's starting for them.
Thank you. Sheila, what is the most important thing that you think about when making a treatment decision?
I just think, like Marina said, that for me, there's no right or wrong answer because you don't know. Like, you don't know whether it's going to work. You don't know anything. So I go in it with an open mind, and I go in it, and it's going to work for me. You know, I'm already thinking positive about it. And then if it doesn't, then we'll try something else with my doctor. But I also want people to know that there's a whole metastatic breast cancer community out there, and that we're right there with you, and you are not alone. And, you know, you can call LBBC helpline, or, you know, I'm plugging, or, you know, just you are not alone, that we're here for you. You know, we don't want you going into this alone. Just know that we're here for you. So, and like I said, there's no right or wrong answer. It's, you know, it's ultimately the decision is going to be you, and you're the person that's going to have to take the chemo and the side effects and everything. So just don't have, like Marina said, no regrets. Just don't go in it with no regrets. Just say, I tried it, it didn't work, let's try something else. So.
Thank you so much for sharing that insight. And thanks to all three of you for being such wonderful panelists, and to all of you out there who joined us for an hour today. Please visit lbbc.org so you can see a recording of this program, and you can also download the 10 questions that I referenced earlier at lbbc.org/balancingact. And quickly before we leave, I want to again thank our sponsors for this program: Lilly Oncology, Genentech, Daiichi Sankyo, Chico's FAS, and Celgene. We will be emailing you an evaluation immediately after this program. We hope that you'll give us feedback so that we can improve our future programs. I want to thank all of you again, and I hope that you all have a very peaceful winter season. Take care.